So glenohumeral ligaments, as the name suggests, they they are nothing but the thickenings of the joint capsule, and they extend from the glenoid labrum to the humerus. Okay. So we are not concerned with the particular attachments of these ligaments, but we should be knowing that where these ligaments are located. So we have three, which includes your superior, middle, and inferior ones. Okay. And your inferior one has two bands. One is your anterior band, another one is your posterior band. Okay, this we all know. And in between these two, we have the axillary recess. So we can just ignore your spiral glenohumeral ligament. That's just anatomical variation. So we are majorly concerned with SGHL, MGHL, and your IGHL, out of which the IGHL is the main one, on which all the injuries of the capsules are based. Okay. So we'll discuss these briefly. More of it should be showing you on the DICOM images. That's how to recognize these ligaments, which is more important. Okay. You can just ignore your attachments. So obviously your SGHL will be the most superior one. Okay. And the origin is from the supraclinoid tubercle. Okay. Two things which you need to remember is, so one is, if you see it on axial images, you will see it parallel to the coracoid process. And if you look at on the sagittal oblique images, on which most of the images of the SGHL are available online, so it will be beneath the coracoid process and the coracohumeral ligament. Okay, so you can just remember these 2 points while tracing the SGHL. Axial images parallel to the coracoid process, and on sagittal oblique images beneath the coracoid process or your coracohumeral ligament. Okay. So we'll look at some sequential images. We are starting from the cranial most aspect of the shoulder joint. So this is the cranial most image. This is basically your supraspinatus muscle. Okay. So now we will be going caudally from this section. Okay. So in the first section, when you see the part of the glenoid, okay, this is basically your coracoid process. You will see a ligament which is running parallel to this. So this is basically your SGH. It's more well visualized on the sagittal oblique images, and it's very easy to recognize. So just have to remember that the SGHL is the one which runs horizontally. Okay? So this is your SGHL, while your MGHL and your IGHL, they run perpendicularly. So again, very easy to recognize. So this is your MGHL, and this is your anterior band of IGHL. Okay? So these will be running perpendicularly from top to bottom, while SGHL will be running horizontally, like this. Much better visualized here. So it's going from the, this is your glenoid. No. This is your labrum. So from the anterior superior part of the glenoid, a horizontal band-like structure. This is your coracoid process. So beneath the coracoid process, horizontal band, we call it as HGHL. Okay. Okay. The bands have been again labeled here. Okay. So sometimes there is a variant. When the MGHL is absent, the SGHL may be thickened, and SGHL can itself be absent in cases of Buford's complex. Okay. So we have studied the Buford's complex, okay, in the previous classes. So in that, the SGHL is absent. The anterior superior labrum from 11 to 2 o'clock position is absent. Along with that, we have a cord-like thickened MGHL. Okay. Now, the awareness of these variants is very important, because so as to prevent the misinterpretation of these variants as tears, because I've seen many residents misinterpreting these as, okay. So you see, the SGHL is thickened in this case. We do not see any MGHL here, okay, because that should have been recognized in the same sequence. Okay. Also, while on axial images, we have already seen, I will told you many times, this is your anterior labrum. Okay. The next thing which should have come here would have been your MGHL, and this is your subscapularis, muscle, and tendon. Okay, so these three are the three contiguous structures on the anterior aspect of the shoulder joint, and we see that there is no MGHL here. So this is the case of absent MGHL with thickened SGHL. Okay, so Buford's complex we have discussed many times. Okay. So we see there is absence of the labrum. There's a thickened cord-like MGHL here. Okay. We do not see any SGHL here as well. Okay. So Buford's complex. Okay. Again the same. Okay, it's better visualized on the diagram images obviously, because by using the diagram images you can obviously move cranially and caudally to assess the insertions and guess and obviously properly guess whether it is the anterior labrum or it is MGHL. Okay. So obviously we see the posterior labrum here. We do not see any anterior labrum here. So this is a thickened cord-like MGHL. Again, better appreciated on sagittal oblique images. So this is your thickened and cord-like MGHL. So before moving on to the middle glenohumeral ligament, okay, let us first see one case. This is the case of recurrent shoulder dislocation. So I'm just purposely showing you this. Okay. So in the cranial mode section, you can see a ligament here, okay, which is going from the anterior part of the glenoid. Okay. This is glenoid. Okay. This is a horizontally directed ligament from the anterior superior part of the glenoid. Okay. This is your MGHL. Okay. Now there can be variants. The MGHL may arise from the HGHL as well. Okay, so don't get confused. Okay. So the MGHL itself can arise from the anterior superior part of the glenoid also, and it can arise from the SGHL as well. Okay. You just have to see the orientation of these ligaments on the sagittal oblique images and then label them. So MGHL will always be directed perpendicularly and SGHL will always be directed horizontally. Okay. So now if you move one section below, this is this is your coracoid process, and this is your SGHL running perpendicular to that. In this case, this is your coracoid. Beneath the coracoid, the ligament is SGHL. Okay. Now, let us move on to the middle glenohumeral ligament. I told you, attachments can be both anterior superior glenoid or it can arise from SGHL itself. Okay. It's the most variable. Okay. And in cases of Buford's complex, it becomes thickened and hypertrophied and compensates for the absent SGHL. Okay. Okay. So we are again well versed. So this is your MGHL. Okay. So tears of SGHL and MGHL are very uncommon. Okay, you will see much. You will see only sprains for SGHL and MGHL, and the tear of SGHL we call it as the rotator interval tear. Okay, again they're very uncommon. Okay, so most of the injuries of traumatic anterior instability will affect your glenohumeral ligaments, both the anterior band and the posterior band. Okay, the traumatic anterior instability will affect your anterior band of IGHL, while posterior instability will affect your posterior band of IGHL. Okay. So this is just a way how you differentiate the MGHL from the anterior labrum on the axial images. Okay, you just trace the two cranially and caudally. Okay, so the MGHL will be merging with that of the anterior joint capsule just beneath the subscapularis tendon and will be arising from the anterior superior glenoid margin. Okay, so you have to follow both the structures, very easy to differentiate. So like in this case, so this was your MGHL, okay, and this was your anterior labrum. So when we followed it below, this was the labrum, this was your MGHL. Further following it caudally, and we ultimately see it starts to get elongated and merge with that of the anterior joint capsule. Okay. So now we come on to the most important of all the three glenohumeral ligaments, which is your IGHL. So IGHL, we should all be knowing. Okay, three things very important: anterior band, posterior band, and in between that we have the axillary pouch. So as a part of adhesive capsulitis, we see there's fluid accumulation in the axillary pouch. There can be synovial proliferation also in the axillary pouch. Okay, and we also in some books you will find it as the axillary recess as well. Okay, so it's basically a U-shaped structure because it has two bands, and it's one of the main stabilizers of the shoulder joint. Both in the anterior band is for preventing the anterior dislocation, posterior band for posterior dislocation. Okay. So now they can be disrupted from their either the glenoidal attachments or they can be from the humeral attachments as well. So the term we call it as the GAGL gaggle, which is the glenoid avulsion of the glenohumeral ligament, and one is your haggle, which is your humeral avulsion of the glenohumeral ligament. And very rarely we can have a tear of the intrasubstance tear, which is seen in the axillary pouch. Okay. So this is basically your anterior band of IGHL. Again, these can be seen both on axillary images as well as the sagittal oblique images. Okay. And this is your posterior band. Okay. This region is basically your axillary recess slash pouch. So in this case, there's a lot of glenohumeral joint diffusion. Okay. So otherwise you will not see just that they are just like you see in this image. So this is the anterior band, this is your posterior band, and this is your axillary recess. So anterior band, posterior band, and in between we have the lax fold. We call it as the axillary recess. Okay. Okay, so when there is less of effusion, so you will see the bands more properly here. Okay. And the anterior posterior bands are relatively more hypointense in comparison to the lax fold in between. But this whole fold is basically your axillary recess. Okay. Now you can visualize these on the axial images as well. Okay. You can see the corresponding section here. So whenever there is joint effusion, obviously they will be stressed. So this is your anterior band of IGHL, and this is your posterior band of IGHL. Okay, so they will be going from the glenoid towards the humerus on the inferior aspect of the glenohumeral joint. So that is why we call them as IGHLs. Okay. Now, the signs for GAGL and Haggle, they have been basically described on the coronal oblique images. Okay. So now you get so the main important point you need to remember about the inferior glenohumeral ligaments is they are the ones which are maintaining your connection between the extracapsular space and the intracapsular space. Okay. So the capsule is just lining these ligaments itself. Okay. So whenever there will be a tear of the IGHL, there will be a tear of the capsule as well. So whenever there's a tear of the capsule as well as the IGHL, the intracapsular fluid now will move on to the extracapsular spaces. Okay. So when you see the joint effusion, it is limited by the joint capsule because there is no tear of the joint capsule as such. Okay. So if you look at on the coronal oblique images, again they will be U-shaped. Okay. This is your glenoid cavity area. This is your humeral neck where they're attached. Okay, and so they are thin hypointense structures forming a U shape here. Okay, so they are the ones which are maintaining the intracapsular fluid in its space. Whenever there will be a tear, okay, uh, obviously a complete tear, this end will now start moving into extracapsular spaces. Okay, so there will be extracapsular collections which will be forming if there's a tear of the, or there is a avulsion tear of the, either from the glenoid side or the humeral side of the glenohumeral ligament. Okay, so you have to remember normal U shape on the coronal oblique images. Now let us move on to the lesions, which are again very important. Okay, they are, so most of the people who are reporting traumatic anterior instability, they forget to look at these. But again, they are very important because now the joint space is now communicating with the extracapsular area. So the joint fluid now moves there. So the chances of degeneration, they become very high if do not repair these lesions. So even if you now repair the Bankert lesion, you repair your Hill-Sachs lesion, okay? But if you forget to repair your eye, still the degeneration will set in very fast because the normal joint fluid which is required for these, let's say for the lubrication of the joint space, that will also be lost into the extracapsular spaces, okay? And no, there can be partial tears also. If you see the IGHLs, there should be very thin hypoindense bands. If they're thick with wavy contour, so they can either be a partial tear or it can be stretching as well. Okay, but still, there will be no extra. But in partial tear, there will be no extracapsular movement of the uh, joint effusion. Okay, so for joint effusion to move into the extracapsular space, there has to be, okay. So we are talking about the IGHLs now. So IGHL can be seen on axial images, sagittal oblique images also, and your coronal oblique, all the three images. Okay, all the three images, they have different uses. Okay, so first, if you look at the sagittal oblique images, so this is your anterior band, this is your posterior band, and this area is your axillary recess. So this is best to assess the fluid in the axillary recess and tears in the axillary recess. Okay, next is your axial images at the inferior level. So this is your anterior band of IGHL. This is your posterior band of IGHL. Obviously, you cannot visualize the axillary recess on the axial images. For that, the sagittal oblique images, they are the best. Okay. The most important for recognizing the injuries like haggle, gaggle, okay, so that is require the coronal oblique images. Okay, so before we move on to the injuries, you should be knowing how do the normal IGHLs look like. Okay, I've seen many residents who are in adhesive capsulitis, they are writing there is thickening of the bands of the IGHL. Okay, but they do not know where the IGHL is located, and they are not able to show me even how to assess the IGHLs on the different images. Okay, so first we should be knowing where to see the IGHL. Then only we can say that it is torn. Okay, so on coronal oblique images, obviously if you are on the anterior aspect of the joint, that you will see your anterior band, and if you're on the posterior aspect of the joint, you will see the posterior band. So this is your humeral head, and this area is the glenoid. You will see a thin hypointense band which is running from the glenoid to attach onto the neck of the humeral head. Okay, so this is your IGHL. If on the anterior aspect, it's your anterior band of IGHL, and if it's your posterior aspect, the posterior band of IGHL. Now, the main function of IGHL is the capsule is lining along HL. So whenever the IGHL will be torn, the capsule will also be torn. Okay, so we have a intracapsular joint fluid here. Okay, so whenever there is a tear in the IGHL, this fluid will come into the extracapsular space. So if you see in a shoulder dislocation patient, extracapsular fluid collection, always assess the IGHL integrity. Okay, because again, the reason I told you, even if you repair Bankert, you repair Hill-Sachs, but you forget to repair the IGHL, again, the degeneration will set in very early. Okay, within 4 or 5 years, advanced glenohumeral osteoarthritis will set in. Okay, So extracapsular extension of the joint fluid whenever there's a tear on the IGH. So the shape is normal U shape, okay, on the coronal obliques in a normal IGHL. Okay. So let us move on to the tears. Very simple tears now. Okay. So two types, partial, complete. Partial, obviously, there will be thickened and wavy contour, which obviously we see in all the ligaments we have been studying, like an ankle. So thickened, wavy contour, intrasubstance, signal intensity, alteration, partial tear. But if it's completely discontinuous, it has to be a complete disruption. Okay. Now the classical U shape will now change into a J-shaped configuration. Okay, that is a hallmark of humeral eversion of glenoid ligament. I'll show you that. Okay, and please remember this J sign has been described for right shoulder. Okay, in cases of left shoulder, this will change to reverse J sign. Okay, so don't get confused. Okay, so this classical J sign has been described for the haggles of right shoulder. In haggles of left shoulder, you will have the reverse J sign. I'll show you also on the images. And if along with that, it takes a tiny so like the difference between the osseous pancreas and the non-osseous pancreas, same way we have the bony humeral eversion of IGHL if it takes a fragment of the bone along with the humerus. Okay, so this is a left shoulder which has been shown. Okay, the first clue what you see here is that this is the intracapsular joint fluid, which is now moving into extracapsular spaces. Okay, means there is some loss of the integrity of the IGHL. And if you look carefully, we see the glenoid attachment of the IGHL, and we see that all the fibers they have retracted at this place. Fiber which is going towards the humeral attachment. Okay, so this is a humeral eversion of glenohumeral ligament. Okay, since this is a left shoulder, so we see the sign is reverse J sign. Okay, the first clue which you will get for this will be your extension of the intracapsular fluid into the extracapsular spaces. Okay. Similarly, you can see this on the axial images as well. Okay. So, and obviously your fluid will be going into the capsular spaces. Okay. Now let us compare the normal. So this is normal U-shaped, thin, hypointense band of IGHL, and the intracapsular fluid is in the intracapsular space only, not extending into the extracapsular space. Okay. First clue in the second image, this fluid extending to this side. If you look carefully, you see a hypointense structure which is forming a J shape. Okay. So this is haggle of right shoulder. Okay. Very simple to detect. If you know where to see the anatomy, the tears are very simple to detect. Okay. So the first clue which you will get is, okay, so if the eversion happens from the humerus, we call it as the haggle. If it happens from the glenoid, we call it as the gaggle. And if the eversion happens from both the ends, from humerus as well as the glenoid, we call it as the floating IGHL. Okay, why floating? Because it has been torn from both the ends. Okay, so I hope this extra-articular, if you're doing arthroscopy, you will see the contrast leakage into the extra-articular space. Okay, so bony avulsion, if it takes a small bony fragment with itself, we call it as the bony humeral avulsion. Okay, so in this case, you see a small shift fragment which is seen near the humeral neck. So this was actually a case of prior bony humeral avulsion of the glenohumeral ligament.